What's up, Feral and Volunteer Ambulance Corps? It's John Barr back again, episode 20. This time we're going to be talking about abdominal emergencies. As per usual, take a few minutes to review the disclaimer. All right, what are we going to talk about today? First, I'm going to tell you guys about the concept of pretest probability because that came up recently in a case I had responded to as a pre-hospital physician. We'll then talk about the important history findings for abdominal pain, talk about the physical exam, the differential diagnosis, some special considerations for special populations, and lastly, we'll talk about treatment and when you might need ALS in these situations. This is going to be kind of like a general review lecture, so sit back and enjoy. First, I want to introduce the concept of pretest probability. Now, this concept is not applicable only to abdominal pain. It's applicable really to any situation, but in light of a recent case I had, I think this concept is not well taught to EMS, and so I want to introduce it here because I think it matters for abdominal pain, and I can show you an example. So what the pretest probability is the likelihood that a patient has a given disease before any diagnostic test is known. So it's essentially your assessment as a provider of how likely or what chance that the patient has a specific disease. Now, what are the factors that go into the pretest probability? So one is the disease prevalence, right? If it's a common disease, it's a higher pretest probability. What are the patient's signs and symptoms? Do they fit with a particular disease? What is the patient's demographic information? For example, some diseases are more likely to occur in the elderly, whereas other diseases are more likely to occur in young people. Or for example, certain diseases are higher likelihood in women. For example, a pregnancy complication is more likely in a woman, to cite an obvious case. What is the patient's family history? Have other family members had it? And then a big part of it is also clinical judgment, or that subjective sort of gut feeling or intuition plays into pretest probability. And sometimes we have clinical prediction rules. These are usually in the hospital. These are things such as the Wells criteria or Geneva score, for example. Those are two clinical prediction rules to assess the pretest probability of a pulmonary embolus or blood clot in the lungs. Most of the time in pre-hospital settings, we're not using clinical prediction rules, but you should be aware that they can be used to help inform pretest probability in certain cases. Now, some of you might be wondering, well, do I have to do this math on scene? No, the answer is you don't. You really just have to look at it and say, does the patient have a high pretest probability of a given disease or a low pretest probability? Now, in the hospital, when I think about this, if I think the pretest probability is high enough, I'll order a specific test. Now, in the EMS setting, you don't have a specific test, but what you do have is transportation to the hospital where you can get that test. So where I see EMS providers go astray is they'll look at someone and they'll think, they don't need to go to the hospital, not realizing, and they think that because the patient maybe looks well on scene, but they haven't considered, well, what's the pretest probability that they have a serious diagnosis? And if they have a serious diagnosis, in general, they should be transported to the hospital, or in this case, if they could potentially have a serious diagnosis, they should be transported to the hospital. Now, this will generally apply to almost everyone, right? Because without blood tests and x-rays and lab work, most people are still going to have the potential of a serious diagnosis. And if it was serious enough to call 911, they should generally come to the hospital and get evaluated unless they've been really extensively counseled on the risks and benefits. So that being said, I wanted to just introduce this as a theoretical concept so you'd have some idea of pretest probability. Now, many of you would be like, oh, I already have been doing that. I've been thinking, well, is this patient high or low risk when I'm deciding whether or not to take them to the hospital? If you have been, great, and now you know the word for it. And if you haven't, start to think, how serious or what's the chance that this person has a serious disease? And most pre-hospital patients have a reasonably high chance. In medicine, we generally accept a 1% miss rate, so most people have a higher than 1% chance within the limitations of a pre-hospital evaluation, and should generally be advised to seek evaluation by a physician in the hospital. Now, what about the medical history for abdominal pain? Well, it's really going to depend on if it's medical or trauma, because that drastically changes the differential diagnosis. We're going to focus on medical causes during this lecture. So for medical causes, you're generally going to get OPQRST, which is onset, provocation, quality, radiation, severity, and time. So what is onset? Onset is when it started. Sometimes I find people confuse that with time. Time is really how long has it been going on for? Has it been a few hours, a few days, a few weeks? And then is it coming and going or staying all the time? Whereas onset is, oh, it started at 3 o'clock today, or it started 3 weeks ago. Provocation and palliation is very simple. It's what makes it better or worse. Does standing or sitting make it better or worse? Do certain medications make it better or worse? Do certain positions make it better or worse? Quality is the patient's description of what the pain feels like. Radiation describes how or if the pain is moving anywhere. So does it radiate and sometimes abdominal pain might radiate to the back or might radiate down a leg or something like that. And then severity is a assessment of how severe it is from 1 to 10. That's the classic way to do it. To be honest, most of the time it doesn't clinically lead to any meaningful difference if the patient says 1 or if the patient says 10. What really matters more is it mild, moderate, or severe? Are they writhing around on the bed like uncontrollable pain, or they're sitting there looking pretty okay? So the number isn't as important as the qualitative assessment of their pain and their subjective assessment of their pain. Now, sometimes it is helpful to get a number. Let's say you're going to give a pain medication. You can then see, well, how much did my medication work? Did it drop at 2 points, 1 point? So that can sometimes be helpful. So anyway, classically, it's from 1 to 10. At least try to figure out, is it mild, moderate, or severe? Now, physical exam. For the abdominal pain patient, the physical exam is really important. And most of the time, people, I think, are taught to check the physical exam in terms of different quadrants. So they'll palpate or press on the abdomen in 4 quadrants, typically right upper quadrant, right lower quadrant, left upper quadrant, and left lower quadrant. That's what I learned in EMT school, and I think this framework holds up pretty well. Sometimes people have learned this other model here where you'll see it's actually divided into further subdivisions. I think the most helpful ones to know for pre-hospital settings are epigastric and what's called either hypogastric or suprapubic region. Sometimes those can give you more of a clue about specific diagnoses. Otherwise, if you just group it by 4 quadrants, that's generally adequate for pre-hospital settings. Now, what are you looking for when you press on the exam? One, you're looking for the location of the pain, and there's a difference between pain and tenderness. So I could say that, hey, it hurts me on the right side of my abdomen. That's different from right-sided tenderness. Tenderness is when I press on the area and elicit the pain. If I press on the area and it's not hurting, well, the patient has subjective pain but doesn't have objective tenderness. In any case, if they're having pain in a particular area, it's helpful to know what organs are in that area because that guides what the possibilities could be. So right-sided abdominal pain, if we start with the right upper quadrant, you would start thinking about problems in the liver or the gallbladder. As you can see in the diagram, we've got the liver and the gallbladder on the right side. On the lower side, you can actually have appendix or appendicitis. And on the left side, you're looking at the spleen and the stomach. In the left lower quadrant, you have bowels, so something like maybe diverticulitis. Now, not shown in this picture are also the gonadal organs, for example, ovaries. So ovaries can present with lower quadrant pain. Testicles can sometimes present with abdominal pain. And I'll start to go over that differential in more detail in just a moment. So let's focus for a second on the right upper quadrant. So I mentioned the liver and the gallbladder. So that's these diagnoses right here. So cholecystitis is an infection of the gallbladder. You can also have cholangitis, which is a severe infection there. Biliary just refers to any disease process of the gallbladder. Sometimes people can have biliary colic, which is a gallstone causing pain. In the pre-hospital setting, it doesn't matter which they have. You just know it's enough you need to take them to the hospital. Hepatitis can also cause pain there. That's an infection or inflammation of the liver. Pancreatitis, common cause of severe abdominal pain, that can be more epigastric. That's why it's technically in the right, but it's almost more epigastric, and that can cause severe pain, often triggered by alcohol, can be triggered by gallstones, medications, or sometimes idiopathic, and we don't know what triggered it. Renal colic is basically a kidney stone, and that can cause severe pain, and you can feel that in the right upper or lower quadrants, really, depending on where the stone is. Duodenal ulcers often have pain on the right, sometimes in the left upper quadrant too, or epigastric region. And then don't think just because the patient's reporting abdominal pain that the problem can't be in the chest. So right lower lobe pneumonias, even heart attacks can present as abdominal pain, especially upper abdominal pain. So don't forget about other types of diseases that could be causing the abdominal pain. Now, if we move a little bit lower to the right lower quadrant, you can see appendicitis is on top of the list. Cecal diverticulitis is diverticulitis in that area. That's basically an outpouching of the intestine that becomes inflamed and infected. Colitis, or inflammatory bowel disease like Crohn's or ulcerative colitis or infectious colitis due to a GI bug, can often cause pain there. I mentioned the kidney stones can also be felt there, and so can abdominal aortic aneurysms. And these might be central, they might be a little bit to the right, but this can cause severe pain. And if you feel a pulsating mass, generally you don't want to touch it anymore. Make note of it, and that's it. Inguinal hernias. So hernias can occur in the lower quadrants. The gonads, so testes and ovaries, can twist, and that can cause severe pain. And in women, you also want to consider ectopic pregnancy, ovarian cysts, pelvic inflammatory disease. That can be due to STIs, for example, and endometriosis, which are deposits of endometrial tissue outside where they're supposed to be in the endometrium. What about the left upper quadrant? So pancreatitis listed again here, right? Pancreatitis is kind of in the middle, so it goes in both quadrants. Renal colic, again, can be on right or left kidney side. And then things of the stomach. So gastric ulcers, gastritis would be stomach related, spleen issues. And again, don't forget the chest, lower lobe pneumonias, and heart attacks. What about the left lower quadrant here? So again, diverticulitis, this time in the sigmoid area, okay? Colitis, renal colic, a lot of the same stuff that we saw on the right can also be on the left because the organs are bilateral. Diverticulitis classically presents on the left. The rest of these can sort of be on either side depending which side is affected because they're often referred to bilateral structures or things that can occur either side, like endometriosis can occur anywhere, either side. I should also point out that those diagnoses are not exhaustive. Now, here's some additional diagnosis. So remember we talked about radiation. Where does the pain move? Well, sometimes problems in the belly present as referred pain to other parts of the body due to reciprocal innervation. So biliary disease or problems of the gallbladder can often present as right shoulder or scapular pain based on the innervation. Kidney stones often present as testicular pain, and also vice versa. Testicle issues can present as flank pain where the kidney is. Perforated hollow viscus, so this is a hole in the stomach or the intestine, that can also present as shoulder pain. And a lot of times the reason for that is the contents leak out into the abdomen and irritate the diaphragm, and the diaphragm innervation goes up to the shoulder. The same is true for why biliary disease causes shoulder pain. It's right under the diaphragm there, and you can feel that pain subsequently in the shoulder. Pancreatitis classically radiates to the mid-back. Ruptured ectopic, again, because blood can leak out, irritate diaphragm, you can feel it in your shoulder. And a lot of times, rectal and prostate disorders just present as low back pain. So let's talk about some special populations when it comes to abdominal pain. So let's talk about the elderly. So I mentioned before the concept of pretest probability. If you have an old person, elderly person with abdominal pain, the pretest probability that they have a serious diagnosis by virtue of being older is high. Almost all elderly patients, not all, but almost, many of them who come to the emergency room will end up getting a CT scan of their abdomen simply because the pretest probability is high. In some studies, up to 1/3 of these patients who are presenting with acute abdominal pain will require emergency surgery, whereas for the rest of the population, that's about 10%. So it's much higher pretest probability. So if you have an old person who says that their stomach hurts, you should take it seriously because their pretest probability of disease is high. And that's an example of what I mean by pretest probability is the likelihood that they'll need surgery or some intervention, or even just that they need diagnostic testing to figure that out is high and they need to come to the hospital. Women of childbearing age are another special population because they're diseases of the ovary. So for example, ovarian torsion, which you see on this side, is a twisting of the ovary, which can cut off the blood supply. In males, you can have the analogous testicular torsion. In women of childbearing age, you can also have ectopic pregnancies. This is where a pregnancy embeds in the fallopian tube or other location that's not in the uterus. And this is a life-threatening emergency because it can rupture and lead to massive bleeding, shock, and death. So you want to have a high index of suspicion. Now, I can tell you many times I have had patients tell me there is no way they could be pregnant when in fact they were pregnant. And this happens many, many times. So really most women of childbearing age merit a pregnancy test because the amount of times we've missed, the amount of times that people have been pregnant who thought they couldn't be pregnant is just very high. Because the patient's on birth control, that's also not a guarantee either. Even though birth control is highly effective, I have seen people with, for example, an intrauterine device in place who then end up with ectopic pregnancy. And so these things can still happen. Now, I mentioned the elderly. On the other side of the spectrum are pediatrics, and kids are really hard to assess with abdominal pain. Many times they'll complain with abdominal pain and it's due to strep throat, or many times it's due to an abdominal problem like a volvulus or intussusception or appendicitis. Kids often have atypical presentations and they're very difficult to diagnose, and as many as a third of them, when they come to the ER, we still don't figure out the diagnosis in the course of a single ER visit. So it's very challenging, and because of that, they really do merit transfer to the hospital to get further evaluation. Now, some also things to consider. What can you do in the pre-hospital setting? You can get specific pediatric past medical history. So one of the best things to do is if the patients have stomach pain, especially if they have nausea and vomiting, is figuring out how much are they peeing. An easy way to ask that is, well, how many wet diapers are they making? Are they making more or less than usual? It's also helpful to get their birth history, if they were born by vaginal or by C-section, if they were born premature, if there were any problems at birth. That can be helpful. If they have all their vaccinations up to date, that can be very helpful. It can be helpful to know, especially if they're a baby, if they had good prenatal care or not. And so, again, you should have a higher pretest probability in the pre-hospital setting for these patients that they really need to be evaluated in the hospital. And so, something to consider, again, how that concept applies. And this is another patient population that has a high pretest probability of serious disease, and that's the immunocompromised patient. Now, that may be due to a kidney transplant, for example. That may be due to HIV or AIDS. That may be due to cancer, leukemia, or some other reason. But at the end of the day, if you don't have a normal working immune system, the pretest probability of you having a serious cause of your abdominal pain is much higher. In some cause of abdominal pain, for example, typhlitis, is unique to the immunocompromised population. That happens to be unique to patients with neutropenia or low neutrophil levels. And you're not going to be able to diagnose that in the pre-hospital setting. But what can happen is you get fooled, right? The patient will say, I'm okay, and their vitals will look decently okay, and the patient looks okay, and you say, okay, well, I guess I'll let you refuse. And while you could still, do a refusal potentially on that patient, you really need to counsel them that, hey, you have this additional risk. You're immunocompromised for whatever you have, and so the chance that you have something serious is much higher than everyone else. And so you really should get checked out. And so that's where it can sometimes help you to have those conversations. And again, I would encourage these people to go to the hospital, at least be seen by a physician and determine if further testing like labs or CT scan is needed. And in most immunocompromised patients with abdominal pain, they will need some sort of lab or imaging test. Lastly, I'll mention obesity and bariatric surgery patients. Obesity is an epidemic in the US. Bariatric surgery is getting more common and more common. So you may see some post-op patients, and they're at risk for bowel obstructions, ulcers, bleeding, perforations, which are holes in the intestines or in the stomach. Depending on the type of surgery they had, it can be in different places. It's also very common to have irritable bowel or dyspepsia in these groups. Dyspepsia is when you kind of hit acid reflux and upset stomach, and you can have inflammation in the stomach area. So again, a higher risk population, again, higher pretest probabilities of disease, and that should push people to get checked out in the hospital where we can do diagnostic tests and further assess it out. Let's talk a little bit about how you can treat this and when you need ALS. Now, for the most part, abdominal pain is going to be BLS because even if they have a serious abdominal diagnosis, there's very little that street paramedics can do in most cases. Most of these patients need a physician, they need labs, and they need some sort of imaging like a CT scan or an ultrasound, for example. And that isn't available in most pre-hospital settings. Very few systems have pre-hospital ultrasound or labs, and even then you don't have the results. So pretty much they need to get to the hospital, and you can provide that as BLS. You can transport them to the hospital. Now, when might be a situation when you may need ALS? Well, one, if the patient's in shock. If you're having belly pain and they're hypotensive and tachycardic, and we've covered shock previously, but if they have signs of shock, they're going to probably need IV access, IV fluids, other ALS interventions, and you might need ALS for that. And then the other group is the patient in just severe excruciating pain, and they may just need some IV pain medicine like morphine or fentanyl or another analgesic of choice. So Pain medication might be another need for ALS if they're really in severe pain. So let's summarize what we talked about. So pretest probability is just a general concept that applies really to any problem, but I want to at least introduce it here. It's the likelihood that the patient has a disease before you do any testing, and patients with high pretest probability should come to the hospital and get evaluated. And in the pre-hospital setting, that's going to be essentially everyone, right? You're going to recommend they come to the hospital because you don't have all the information to fully assess them in the field, and so if they're feeling sick, they should generally go and get checked out by a physician, get the blood work, get the imaging they need. Taking a good history in the pre-hospital setting can really help inform the differential. Especially remember that in the abdomen, differential often starts with the location. And a lot of times the information you get on scene is the only information we get to go on in the hospital. So getting a good history is really helpful. The belly, when you feel it, should feel soft. If it feels hard, that patient's really sick. You need to come to the hospital. Okay, so a firm abdomen, you're in trouble. Remember that the pretest probability of serious disease is generally higher in special populations. So again, transport to the hospital. I can't specify enough, transport to the hospital is the safest thing you can do in the pre-hospital setting. And then lastly, most abdominal pain can be transported by BLS, but if the patient has shock or extreme pain or there are other extenuating circumstances, you may need ALS. So with that, stay safe out there, and I'll see you guys on the next one. Take care.